Here we go. Welcome, everyone. I want to introduce Dr. Kevin Huguet and Kelly Tyrell, nurse practitioner. They are here to talk about The Wait is Over, new treatment options for weight loss. Thank you very much.
Alrighty, thank you, Jean Marie. I'm Dr. Huguet, and I have Kelly here with me. And today we're going to be giving a broad overview of current trends and treatment options for weight loss. Just to give you some background, I'm the medical director of the Metabolic and Bariatric Center at St. Anthony's, and then the founder of the MIIS Weight Loss Institute here in St. Petersburg, Florida. So we specialize in weight loss surgery and then non-surgical treatment for weight loss or medical weight loss as well. And then we have Kelly. She is our nurse practitioner. I'll kind of turn the monitor over to her to introduce herself there.
Hi, I'm Kelly. I'm the nurse practitioner here. We started originally with the surgical management of patients and then started incorporating the injectables now and meal replacements and other options for patients that might not necessarily qualify for surgery. So we're going to touch on that as well today.
All righty, so we have a hot topic to review and not a whole lot of time to go. So hopefully we can get through everything and make this a good, meaningful presentation for everybody. So here's what we're going to talk about. We're going to first just go over obesity and its health implications. And then we're going to move on to the treatment options and kind of an update on surgical versus medical treatment. And I know there's a lot of buzz out there around some of these new medical treatment options for weight loss, including what we call the GLP-1 agonists. So we will be getting into those as well and give you kind of an update on the data and how it presents itself for those patients that want to take that. And then we're going to compare the two and give you an idea kind of a broader view of both of those compared. And there will be time at the end for questions as well. So just getting into it. So obesity is a very common problem in the United States. Over the past 2 decades, it's really just become more of an epidemic, I would say. It's also a dangerous problem, and people often don't associate with obesity and think of it as something dangerous, but you can lose an extra 10 to 15 years, die an extra 10, 15 years earlier in life related to obesity. And it's also a lot more expensive to your budget. It can cost 41% more than, say, the average person based on doctor's visits, medications, diet programs, etc. So it is a dangerous problem that I think we need to take seriously. You will frequently hear us describe a BMI, which is a body mass index, and that's an equation we use to kind of calculate somebody's level of obesity, and then we stratify them on what our best recommendation is for their weight loss options. And it's divided into classes, usually class 1, 2, or 3. And that's once your BMI is over 30, you reach class 1 obesity. And so that goes 30 to 35 for class 1, 35 to 40 for class 2, and greater than 40 for class 3. And then in this particular slide, we do have the insurance, not insurance, but I guess the general recommendations that insurance follows for weight loss surgery based on your class or level of obesity. Fairly recent changes over the past 2 or 3 years they've now lowered it to patients with type 2 diabetes now meet criteria for weight loss surgery when your BMI is between 30 and 35. And that's a fairly newer finding, and it's strongly supported based on data showing how beneficial it is to treat diabetes with weight loss surgery. But we'll get into a little bit of that later. So how risky is obesity? So once you get to class 1 obesity or your BMI is over 30, there's a significant risk to your life. It's associated with a 55% increase in mortality, 70% increase in heart disease, 75% increase in stroke. And the biggest thing is diabetes, 400% increase. So we know there's a direct correlation between diabetes and obesity. And I think, honestly, a lot of the illnesses and issues and what we call comorbidities come from having diabetes. So if we can simply get that one disease element under control, a lot of these other illnesses tend to go away as well. Why is it so challenging? Why is this such a big problem? And it all comes down to something we kind of put in a very basic form. We call it the set point theory. And that's more of something we use for discussions about weight loss surgery. And the reason is that patients are always frustrated with, I've tried all these diet plans and nothing seems to work for permanent weight loss. And I would say 99.9% of my patients struggle with this. And it's something we understand that's going into what we expect. And basically it comes down to, we in a very kind of layman way of putting it, we say your body has a set point, a weight where it wants to stay in your adult life. And it tends to go up over time. And it's a physiologic set point based on multiple factors that we'll get into. But really the only way to change this set point is to alter something in your body. Because what we're going to talk about is permanent changes that we need to do to get the weight off and keep it off permanently. So permanent lifestyle changes. And so what contributes to this set point, or what causes obesity, is multifactorial. So you see all the pieces in the puzzle here. We have genetic influences. I think personally, that's probably one of the biggest influences that relates to obesity. And basically your physiology or your genetic makeup. And that's why I'm sure a lot of patients recognize a strong family history of obesity in all of their relatives. And that can't all be just behavioral. I think we have to recognize that a lot of that is just genetically, this is what the hand they've been dealt. And so we need to handle it in a way that addresses that. It's multifactorial, so we can't say it's just genetic. There's environmental issues, like the kind of foods we eat biochemically, how your body metabolizes food. And then there's some neurologic, physiologic, and cultural issues as well. But in my opinion, I think the largest piece that should be on there is probably going to be genetic, in my opinion. And this is what we kind of mentioned earlier, but permanent weight loss is really what we're talking about, because anything that's temporary in the whole scheme of your adult life doesn't make a huge difference. If you lose 100 pounds over a 1-year period and then you regain that 100 pounds, in the end, looking back on your life and the damage from obesity, it won't make too much of a difference. But if we can get weight loss off, or get weight loss accomplished and keep it off, then that's going to be a huge, substantial benefit to your other illnesses in life. So and a permanent lifestyle change is basically required for any weight loss treatment to be successful in the long term. And this is just a slide that I found online. It's not a diet, it's not a phase, it's a permanent lifestyle change. And I strongly support that. So whatever we do, it's got to be able to keep weight loss off permanently. So what are the treatment options for obesity? We know there's, we've kind of broken it down on a pyramid here. So there's diet, exercise, and behavioral change. And these are kind of lifestyle modifications. That's kind of the most common thing most people have tried. And most of the time, it's not that successful, unfortunately, when we're treating true obesity. Next up would be like weight loss medications. And this is the one that's become very popular lately. And then lastly would be surgery. And this is actually, this pyramid also shows what's very common and who actually has treatment. And that's most commonly, it's lifestyle modifications followed by pharmacotherapy, now followed by surgery. Surgery is classified into three main surgeries are done, but there's a restrictive and what we call restrictive and malabsorptive. So we're going to try not to get too technical with you here, but restrictive would be things like the old gastric banding or the sleeve gastrectomy. And then there's malabsorptive, which would be things like a gastric bypass or what's called a duodenal switch. So the old banding procedure was originally done in 2001, and it was very popular for about 10 years. And then we realized that it really wasn't as good of a long-term solution. And then what actually happened is the sleeve came out as an effective treatment and kind of replaced the lap band. So bands are done less than 1% of the time now. Most of the time patients have a band, we will remove the band and then convert that to another weight loss operation, most commonly the sleeve. That was one of the more popular ones about 10 or more years ago. The sleeve gastrectomy is now the most common weight loss surgery that we do, and it makes up, I would say, somewhere around 60 or more % of the weight loss operations that are done in the United States. And with this operation, we basically staple off a portion of the stomach, and then we remove somewhere around 70% of the stomach. The reason it's become so popular is because it is so safe and so effective. And this is one of the safest surgeries I do overall, and by far in comparison to all the other weight loss surgeries, by far the safest one. So that's why it's really taken hold over the past 10 to 15 years, and now become the #1 weight loss operation performed in the United States. Bypass you've heard of, and that's the one that is a little more invasive, and they reroute intestinal flow. And so with that one, there's some malabsorption and some side effects that go with that. It is an effective treatment. And initially, you might get a little more weight loss with the bypass than you would with the sleeve gastrectomy. And then there's varying results in the long term of, in the end, they are very similar in weight loss. The bypass might have a little bit more. But there are some other issues with the bypass that we do review in discussions. And there's some patients that we do recommend a bypass versus a sleeve, and it largely depends on each particular patient and how much weight loss is needed, their illnesses, and other factors that go into discussions. A newer operation called the switch or a SADI, which are a little bit different, but similar concepts, and those are where you combine a sleeve gastrectomy with another weight loss operation or a malabsorptive operation. And unfortunately, most of these aren't covered by insurance. They are effective. They do have their own set of issues and complications, and so they're not performed as commonly, mainly because of insurance hurdles that we run through with these. Just for the sake of thoroughness, I wanted to bring it up today. But I'm obviously biased towards weight loss surgery, and this slide shows you an idea of how much better comorbidities improve, say, with bariatric surgery. And this is just kind of a quick rundown of all the organ systems that are affected with weight loss surgery, with improvement in things like sleep apnea, hypertension, diabetes. Diabetes resolution rate or improvement rate runs somewhere between 60 and 80%. So that's, I think, out of this slide, the most important thing that's going to be life-changing. So we have anti-obesity medications. These are called semaglutide and other named medications. Kelly's here with us, and she will go over all of these. Let me slide this over. There we go.
So the hot topic, as Dr. Huget was saying, is the anti-obesity medications right now are pretty much everywhere. These are a few of the ones that we have for FDA approval. So right now, liraglutide, which is Victoza, originally for diabetes, and Saxenda is a once-a-day injection. This is kind of going by the wayside now because the weight loss isn't as impressive, and it's a once-a-day injection. So the ones you're going to hear the most about, semaglutide, which is Ozempic for the diabetic patient, or Wegovy for weight loss, is an FDA-approved medication. Average weight loss is about 15%. But in practice, we're seeing even a little bit more, so closer probably to that 20%. And as of March of this year, the FDA did approve Wegovy for reduction of cardiovascular disease. So that has opened some doors, especially on the Medicare coverage side of things. But as of right now, it's just for secondary prevention. So a patient has to have documentation of a prior MI, stroke, or peripheral artery disease requiring intervention. So patient selection is important there. If somebody is interested in weight loss medication and they do have a strong cardiac history, I tend to go towards the semaglutide. The other option, the newer one, is tirzepatide, which Mounjaro is the diabetic version. Zepbound is the FDA-approved weight loss medication. These are once-a-week injections. So in addition to the GLP, it also has the GIP. So weight loss in the studies is about the same. On the higher dose, we are seeing up to about 20%. In practice, I am seeing more. However, they do not have FDA approval for the cardiovascular indication, so they are currently working on it. So patient selection is important. I am finding in practice, side effect profile tends to be a little bit more tolerable for patients on Zepbound. Both great options. It just depends on insurance coverage. Some insurances will have Wegovy as a tier 2 and Zepbound as a tier 3. So even if it is covered, it still tends to be pretty expensive for patients. So the most common ones you'll be prescribing or seeing prescribed are probably Wegovy and Zepbound. Frustrations facing prescribers. So this is a big one right now. coverage. Because of the price point of these medications, very few insurance plans do cover these medications right now for true weight loss. Out-of-pocket costs without a coupon or anything is about $1,300 a month for these drugs. And this isn't just a 3 months, I get to my goal and then I'll come off the medication. This is a medicine that they need to take for life. Obesity is a chronic disease, and patients need to understand that it requires chronic treatment. So you have to have that conversation. So out-of-pocket costs right now, there are coupons. The $3.99 price point is for Zepbound, but that is for the base dose. By the time you get to the true therapeutic dose, you're paying, right now the coupon is $650, but that will expire, and then the out-of-pocket cost will be around the $800. Wegovy is $650 a month as well, regardless of the dose. Medicare patients and Medicaid patients do not qualify for the coupon, so it's only patients with commercial coverage who can have access to that. It is employer elected, so it's not the payer, it's if the employer has elected to opt into obesity medicine coverage, then the patient might have access to it, and then the price point does become much more affordable. It's usually about $25 a month. The other issue is the supply. Both semaglutide and tirzepatide are on the FDA shortage list. Tirzepatide did come off briefly, but very quickly the FDA realized that that was not the case, and now they're investigating it again. And I've had multiple issues even this week trying to find tirzepatide for a patient. So that was very frustrating. Patients get frustrated. They're doing really well, can't access the medication for a month, 2 months, even 3 months at a time. We're having to send prescriptions everywhere. So even as a provider, just the pure volume of phone calls can be very frustrating. And the time required to get these medications. So prior authorizations are time consuming. Every single patient requires a prior authorization for these medications for weight loss. Also, these medications require frequent follow-ups. These are titratable doses. So you need to make sure patients are tolerating the medication, that you're putting them on the appropriate dose, that side effects are managed and adverse reactions are. So frequent follow-ups, that I tend to see patients at least once a month, and if they need more visits than that. Once I get them to a maintenance dose, whether it's with Wegovy is the 1.7 or 2.4 milligram dose, I will space them out to 90-day visits if that's what's appropriate for the patient. And then Zepbound has 3 maintenance doses, 5 milligrams, 10 milligrams, and 15. Again, it comes down to how the patient's tolerating and best judgment when it comes to follow-up. But yeah, I think just the last few months, I've done over 140 prior authorizations. So that does, as from a primary standpoint or cardiologist standpoint, that is very, very time consuming. Comprehensive approach. Where we are finding these medications tend to be the best in terms of long-term effects are honestly patients who have had bariatric surgery, and maybe the patient hasn't gotten to a healthy BMI and they need an additional approach with the surgery. It's a great option for those patients. Or in that 10% of regainers, another great option for those patients. It works. I tell patients to think of it kind of like the liquid sleeve. They're going to have that restriction. They're going to have that control over their cravings. But again, it comes down to patient selection. These medications aren't for patients who are just trying to lose 10 pounds for an event. These are patients who are struggling with obesity and need a chronic option. So BMI that's over 30 or 27 with a comorbidity are probably the best candidates for this. But then it's going to come down, for a provider standpoint, you really have to focus on making sure the patient has a good foundation when it comes to their nutrition. This isn't a quick fix. In patients who weren't maintaining a physical activity regimen or maintaining their protein intake, studies were showing that about 40% of the weight loss was actually muscle tone, which looks good on the scale, but it's not good for their metabolism or their overall health. So you really have to push that they're following good dietary habits and maintaining an active lifestyle. So it really just comes down to education, the proper patient selection, of course, and making sure that the patient knows that this is a long-term commitment. They need to be compliant. They need to make sure that they're putting an effort in on their part, and that they will continue to follow up for that long-term management.
Thank you.
Okay. All righty. Thank you, Kelly. Great job. So now we're going to shift gears a little bit. So we talked about how surgery works. We talked about how medications work. And now we're going to kind of review some data on a comparison of the two. It's a little bit skewed towards surgery because that's what we're presenting here. And in my opinion, surgery is more of a long-term solution for people that have severe obesity. And so this is going to be data that's fresh off the press. This one's not even gotten a chance to get published yet. It was just presented at our Bariatric Surgical Society meeting called the ASMBS. And this was just presented this year. And it's where they looked at over 40,000 patients. And they looked at 6 trials and 3 reviews. And the title of it was Surgery Best Lifestyle Changes, GLP-1s, or I should say, and GLP-1s for durable weight loss. Because remember, what we mentioned earlier was this is all really coming down to durable weight loss is what we want. We want something that make you lose weight and keep it off. And so the results show with lifestyle intervention, so no medication help, none of the GLP-1s, no surgery, you lose about 7% of your total weight, which really isn't life-changing and not going to help your comorbidities or other illnesses. GLP-1 medications, it's about a 10 to 20% total weight loss. And then bariatric surgery is about a 30% total weight loss. So usually, Kelly mentioned 15%, but she's seeing up to 20%. So that's great. Usually, from what I see in the studies, it's about half of what you would lose with weight loss surgery, although anecdotally, Kelly might be seeing more than that in her patient population. So that's usually how we look at it. And so this is why a lot of this comes down to what's a right fit for you and how much weight you need to lose and how likely are you to keep this off permanently. The most important part, one of the reasons for this presentation was to go over the weight regain rate, because that's also really important because if you can lose the weight, great, but can you keep it off is the most important part. Lifestyle intervention, we figured out, okay, you only lost 7% of your total weight. And then at 4 years, they had studies about 100% of the time you would regain that. And so we know that I'd say 95 to 100% of the time, if you don't have the assistance of medications or surgery, you will regain that weight, unfortunately. And so what this all comes down to is that set point, because if you're not altering something permanently in your life, then that set point will almost always go back to that exact same weight or usually higher. GLP-1 medications, the ones that were on that slide, it's about a 50% of the weight is regained at a year. We've got data on these patients up to about a year. So you don't regain all the weight, which is good. It depends on how much weight you need to lose and how much you want to keep off. But right now we're seeing about a 50% regain rate. Resurgery. So bariatric surgery, we've been following this a very long time. And so we have very long data on our bariatric surgery population. And the more way they phrased it was they looked at patients up to about a 10-year mark after weight loss surgery, and they retained about 25% of the total weight loss. In other words, they lost 30%, gained back about 5%. In the end, at about 10 years, about a 25% total weight loss at the 10-year mark, which is a good number. And you will see with surgery, you do lose weight fairly rapidly over about a year. And then some patients over about 2 to 5 gain back a little bit, then hopefully plateau at a number that is a good number that prevents all the illnesses that we're trying to prevent with treating obesity. So this is from that same presentation. And I know it looks a little funny with all the different lines, but bear with me here. You'll see this black line and this purple line right here. These are both the 2 bariatric surgeries they followed. So the sleeve gastrectomy and the gastric bypass. And as I said earlier, the gastric bypass kind of swoops down a little more, meaning these are years down here, you lose a little more weight. That's about a 10% difference in weight loss than compared to the sleeve initially. And then over time, the graphs come very close to each other. And so maybe a little more, 10% or so excess weight loss with the bypass, and then that gap narrows a bit. But what it does show you is that you do regain some, but then you plateau here at about the 25% mark. We don't have data on all of the different GLP-1 dosing and things for weight regain, but what we do have is here at the yellow line here, the 20-week mark after the semaglutide was stopped, and the tirzepatide after it was stopped after 36 weeks. And you can see this regain rate. And this is where some of the data comes back at about a 50% regain rate. Not 100%, so that's good, but still something to be aware of as we're choosing what the best option is for us. What we're going to go over now are just some studies talking about, okay, what are the benefits of surgery in the long term? We're getting some of the studies with the GLP-1s in regards to heart disease that Kelly mentioned earlier. And I think we've still got to tease out, is it the medication or is it the weight loss? And I think that's going to be more data to come in the future. So we know with surgery, the risk of death decreases. This is something where we looked at patients over about a 5-year period after they had surgery, and in that same population of patients with obesity that didn't have surgery, and what was their risk of dying. And what we found was over a 5-year period, the weight loss surgery patients had a 9 times lower risk of dying, meaning say 0.7 or 0.7% of the bariatric surgery patients had a mortality rate versus 6% for control patients. So that's some interesting data showing, okay, surgery does affect me over a 5-year period and decreases my chances of dying. And then healthcare costs after weight loss surgery is about 45% higher if you haven't had surgery compared to if you did have surgery, because you still have the illnesses that are causing you to go to the doctor. This is just published this month, and in one of our big journals, the Annals of Surgery. And what it did was it looked at patients, over 400 patients with a BMI over 30 with diabetes and kidney disease. And what they found was that surgery had a 60% lower rate of kidney disease progression compared to GLP-1 medication patients. So just an interesting comparison, because you would think weight alone, but I think there's also something physiologic from surgery that's helping patients here. And then, this is what I love. Kelly, I don't have her slides, but she has some of these, I'm sure, as well. But these are all of our success stories with surgery. And I can tell you, I do a lot of surgeries for weight loss, and this is the best part of it for me, is seeing these patients come in with smiles on their face and really having a whole new view on life. And what the weight loss has allowed them to do. Because, what we're talking about is surgery to make patients healthier so they get rid of a lot of these illnesses. But then beyond that, it's to give them a more active life and a whole new outlook on life. I don't do it for cosmetic reasons, though. It's not cosmesis. It's really about giving patients a whole new life ahead of them where they can enjoy life and do a lot of different things that they couldn't necessarily do before they lost the weight. So choosing the right option. So there is no right answer for all patients. There's a lot of factors to consider. There's your overall health condition and how safe surgery is for you, what your goals are, what you're willing to risk, and how much weight you need to lose. Some patients that need to lose a lot of weight in higher BMI categories maybe should consider something more like surgery, and then much lower BMI categories maybe try the medication. So, and then those patients in the middle are the ones where it's a little more about talking to your providers and seeing what's right for you. But I think it is worth having a discussion about something, because doing nothing, we found in the lifestyle modification slides that just trying on your own with no medication, no surgery, in the end is probably not going to be a successful option. And so at least try something to address it so that you can have a much more healthy and longer life than if you hadn't addressed it. Because we really want to get a hold of this early before it becomes an issue and causes the illnesses that are preventable. And I think we're about right on time, amazingly. So that's all I've got for our presentations. Thank you all for attending today. And I think we can open it up to questions.
We got lots of questions for you. I've
All
kind
right.
of gone through them and I've combined a bunch of them because there's a similar thread to a number of them. And I would say one of the big asks is a lot to do with insurance, because, you hear about the things of, Kelly even talked about how expensive this can be and who covers it. And, does your company have this as part of their plan? So I think some of the questions you're going to need to go address who your provider is for your insurance plan to see if you're covered. But what is your thoughts and what information do you have about, getting these medications covered? If a primary care or a doctor refers somebody, is that a better chance for them to get coverage for this medication? Some people are talking about they have to have certain diagnoses. As we were mentioning, if you have diabetes, then you're eligible for this. So I'm going to let you take that and go with it.
Yes. So I'm going to just it sounds like you're talking questions about just medication. So I'll hand that to Kelly in a sec. But if it is about surgery, we have a patient advocate where everybody has different insurance plans for the surgery. And so that would be more digging in on the surgery side of your benefits that you have. Generally speaking, if you have a BMI between 30 and 35 with diabetes, you are a candidate for surgery now. Over 35, a lot of times they don't require comorbidities anymore to have the operation. So those are generalities, and a lot of it comes down to insurance. And then we do work with insurance companies through all the requirements, and we have dietitians that work through that. Now, in regards to the medications, I'm going to kind of slide to the side here for Kelly, and she can address that.
So when it comes to insurance coverage, most insurances require a BMI over 30 or 27 with a comorbidity. Certain plans can have different variations, but that tends to be the broad one. But it does come down to employers. So the best way to do is call your insurance company specifically and look for obesity medicine coverage. The best thing to do is ask specifically for Wegovy or Zepbound coverage, because you might get confusion if you have coverage for Mounjaro or Ozempic. That might be true, but you have to be a true type 2 diabetic and usually have failed either metformin or another stepwise therapy to get coverage for that. Both Eli Lilly and Novo Nordisk, if you go to their website, have tools for patients to put their insurance card and check their insurance on their own. As a provider, I highly recommend that, so that by the time you get face-to-face with your provider, you know if you have coverage or not. From a provider standpoint, because it requires a prior authorization, most patients have had to either have proof that they've done 3 to 6 months of nutrition and lifestyle modifications prior to initiating therapy. You have to have a BMI over 30 or 27 with a comorbidity. You have to it doesn't really matter in terms of the physician who's prescribing it or if there's a referral. When we look at it from a cardiac standpoint, you have to have documentation of that cardiac history, whether it's the heart attack, the stroke, or the PAD with a surgery. So lots of times if I'm doing it for a patient from a cardiac standpoint, I will request records from a cardiologist or the primary who has that documentation. But from a patient standpoint, the best thing they could do is advocate for themselves through their employer, because if you don't have coverage, it doesn't hurt to ask for coverage. Of quite a few plans, one in particular is the state of Florida. You have to enroll in a specific it's like Healthy Me, and you have to show proof every 6 months that you are following up, that you're getting your labs done, and that you're compliant. And all plans, for the most part, require documentation every 6 months to show that the patient has lost about 5% of their weight to continue the treatment. But yes, it's a very expensive medication, and a lot of payers will drop coverage sometimes. That's kind of one of the things that faces us right now. But the best thing to do is to look. I've been pleasantly surprised. I run into patients all the time who come from small little companies who do have coverage, and then there's patients who work at big corporations who don't. So doesn't hurt to look into the coverage, though.
Thank you. And that is great information, because it is, you need to speak if you're have a commercial insurance through your company, call your benefits program, and they're the ones who are going to be able to really help you with that. If you're looking for the weight loss surgery, they have some advocates for you in Dr. Huget's office that can help you kind of work through that. There's also a lot of questions about the whole thing out there about the compounding. Is there a difference between these medications? I think people hear these words, a lot of compounding of pills, compounding of injectables, the IV bars, the mail-in order type things. Even Weight Watchers is now doing something. Are these legitimate? And what are your thoughts on that?
So Kelly will chime in. Just from a physician's perspective, you've got to be careful with it. There are good ones out there that are reputable, that have like good pharmacies. We work with a pharmacy in particular. It's a national pharmacy, but there's also a lot of ones out there that aren't reputable and maybe or would not be in your best interest. So my 2 cents would be, okay, you got to do your due diligence and make sure it's a very reputable pharmacy. And it is a good option if you don't have coverage or it's too expensive, if you have a good pharmacy that is reputable.
So compounding medication is a tricky subject because there are a lot of pharmacies out there that are not making good quality products, are using derivatives of the base ingredients, and patients are having adverse reactions, terrible side effects. So the best thing to do, like Dr. Huguet said, is make sure you find a provider who uses a pharmacy that is reputable. At the end of the day, yes, the commercially available option is the safest. It is FDA regulated, where compounding pharmacies, the facilities may be regulated, but the drug is not. So you just have to make sure that you do your research, look at reviews. But it is an option. It is all cash pay, and it is still pretty expensive, but it is an option for patients who just don't have the coverage and are looking for help. The one thing with a lot of the online ones is you have to be careful with is they'll advertise an aggressive starting rate, but by the time you're on the therapeutic dose, you're paying 4 to 5 times that price. So it is a good option. It's just you have to be careful and you have to do your research.
And the other part is this is there's no easy path to permanent weight loss. And that I can't stress that enough, that whatever we do, it's got to have accountability, and it's got to be a permanent lifestyle change. And whatever we're doing has got to be viewed as a tool to incorporate with all these other things. So if you want to try something outside of, say, a compounding pharmacy, you really need to do it with multimodal therapy, meaning, education about your diet, physical activity, and encouraging exercise, and then accountability, so that you come in and see somebody and make it sure that you're doing this the right way. In my opinion, if you want to go that direction, just simply going somewhere, getting a drug, and not really doing everything that needs to be done with it would not be the right way to go.
I love how you put that, because weight loss is a multi-billion-dollar industry where a lot of people are trying to grab that cash and trying to give people that easy way out. And no matter what path you take, there is some issues. There are some side effects to it. Looking at even the surgeries, what are the side effects we're looking at there? And let's say I lost 100 pounds and now I have all this extra skin on my body also. Is that something that can be covered with insurance for the cosmetic fix of that, or is that purely a cosmetic change if I have that kind of skin excess?
Very common and very great question. It's really hard to predict what patients are going to have an issue with skin. I can tell you that I feel like it's definitely something that there's a lot of concern, more so than the actual problem that develops in seeing patients, say, preoperatively. Ways that we try to prevent it would be resistance training, good physical activity perioperatively and postoperatively, so you don't lose muscle and your skin stays tight and toned. We also have procedures that can be done to remove excess skin. And then we also have something here that we will be offering perioperatively that might be able to help tighten skin postoperatively to prevent some of this issue. It's a skin tightening device that we have. So those are some ways. Now, in regards to surgery, there are surgeries, and usually it's the arms and the legs, sometimes the abdomen that need addressed. If that's the case, the abdomen can be covered by insurance, but it's very challenging, and it's a process that takes 3 to 6 months, would you say? Where you have to document a rash from what's called the pannus, or the extra skin fold in the abdomen. And then there's limited surgeons that actually offer it, that take insurance. So it can be done. Sometimes you have to leave the city to find people that will do it through insurance for insurance. Most of the plastic surgeons will do it, but not through insurance. That's the challenge. The other parts of your body aren't generally covered. So the legs or the arms, insurance won't generally cover that.
Excellent. There was a question about, what BayCare providers provide this weight loss surgery. This is not just BayCare team members who are on this call, and you do want to talk to your insurance, your benefits department, to ask who can. I do know if you are a BayCare employee, Dr. Huguet is definitely covered by our insurance, so he is someone that you can reach out to, but you can check in with our benefits. We have someone on the call who was able to lose 40 pounds since April. And she just wants to say, she was diagnosed with type 2 diabetes, got an A1C of over 7. Just to kind of reiterate, the only way to lose weight or keep weight off is not necessarily always surgery, but there are extenuating circumstances that you want to kind of look at. So she's kind of asking, what's your thoughts on, can she do this with just lifestyle changes with her 40-pound weight loss?
Oh, so she's lost 40 pounds. She
Yes.
has type 2 diabetes right now, and wondering if she can continue down that path, or is she still somebody that would think about something else? Is that the question?
Correct. She hasn't done any medication. She hasn't done any surgery. She's done this with lifestyle changes. First of all, I want to say great job. It's being able to maintain that and keep up those lifestyle changes. And, what is your thoughts on all of that?
Yes. So some of it would come down to, 40 pounds is a lot of weight on your own. So, great job. That is amazing. And if it's something that you feel like you can do the rest of your life, then go for it. If you feel like you can keep it off, great. Now, it depends also 40 pounds in regards to your total body weight. And if you have, if your BMI is still over 35 or 40 and with the diabetes, then maybe you can take that further with surgery or medications. If you're happy with what you've got and where you're at, and you feel like that what you've done is something that you can continue for the rest of your life, then that sounds great too. But I think from a practitioner's perspective, our biggest target would be to try to get that diabetes either well controlled or into remission.
All right. Another drug question. One is basically, how do you look into a pharmacy to see if it's reputable? And then there's some other drugs out there like Trimova and Benton, PHENTERMINE. What is your thoughts on those in comparison?
So phentermine has been around for a very long time, but it is a stimulant. So a lot of patients who have underlying high blood pressure or AFib or any other arrhythmias or cardiac history are usually not candidates. The weight loss is good, but it is temporary. As soon as you stop the medication, the majority of patients do regain the weight. And then a lot of patients don't like the stimulant side effects of it. So increased anxiety is also another side effect. So when it comes to drug selection, I tend to go look at the patient's history, look at their coverage, and if I have coverage for the GLP, that's usually where I'm going to go. But some patients, maybe they are just trying to lose the 10 or 20 pounds, and phentermine is approved for chronic weight management now. It's not just the 90 days like it used to be, but it is a good alternative for patients who don't have as much weight to lose. And then in terms of figuring out if a pharmacy is reputable, it really comes down to, it's hard to say. I know there's medi spas all over town. Those ones are going to be, if they don't have understanding of obesity medicine, haven't done their due diligence, and maybe it's just an injector who's looking to do that, then you might need to be a little bit careful. I talked to somebody who saw that their nail salon offered it. So you just, some common sense too. A lot of the online ones are probably going to be more reputable, but that comes down to the price point really, and make sure that they're not using salts. The salts are the derivatives where patients were having some adverse reactions, but the product was cheaper. So you want to make sure that the pharmacies are using the real base ingredient and understand the medication. You can also look and see who has an FDA certification for their facilities as well. The one that we use does, but again, I always try to go for the commercially available product first for the patient.
Well, go ahead.
I would say also, Kelly said it very well, common sense. Like, again, this is something that you really should go to somewhere that offers a comprehensive model, because I think that's going to be your best way to get a good product with a good outcome. And I would strongly encourage that, because you really want, just comprehensive care to really manage this, not a quick fix.
That's probably the best way to say it. There is no quick fix. This is something you need to look at your individual health, your individual conditions that you might have. We've mentioned a lot, if you already have hypertension or if you have type 2 diabetes, they are going to impact what choices you make. You want to have this with a trained professional. You want to be with a physician or a nurse practitioner so you can make these choices so that you're getting the best information for you. I want to thank you both for being here today. You gave us a host of great information. We will share these slides so that people can review them and see what's going on. This is being recorded. It will be up on the site in a about 3 weeks. It usually takes them for that. But I thank you all for being here, and we look forward to seeing you next month. And Dr. Huguet and Kelly, thank you so much for your time and your expertise.
Yeah, we appreciate you having us. We had a great time today, and we're happy to help anytime with anything.
Thank you.
Thank you.
Bye, guys.